Hello and welcome to this educational program entitled Tackling Chronic Inflammatory Airway Diseases, a unified picture of disease processes and targeted management. We are honored to have participants from across the country in attendance, not only in this room, but also viewing online. This program is provided by Integritas Communications and supported by an educational grant from AstraZeneca. To answer polling questions, please use the keypad provided. Your responses are anonymous and very important to the outcomes of this program. The information being presented is available online. The link is listed on the card in front of you. This card also provides links to valuable clinical resources, educational activities, and patient testimonials. As part of our ongoing efforts to evaluate impact and refine future activities, please complete and return the evaluation form before you leave. For everyone joining us online, the system will prompt you to answer polling questions, and the information presented is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. Now, let's give a warm welcome to our presenters. Dr. Joseph Han, Dr. Amber Luong, and Dr. Anju Peters. Enjoy the program.
All right, well, welcome everybody. We all are very excited to be presenting today, Tackling Chronic Inflammatory Airway Diseases, a unified picture of disease process and targeted management. Here are our disclosures. So we actually have very lofty educational objectives that you all can read, but basically we'll discuss pathophysiologic processes that contribute to inflammation and hyperresponsiveness and airway remodeling. And we'll talk both about upper and lower airways, including the roles of inflammatory markers such as TSLP. We'll describe the clinical profiles and evidence for biologic therapies to address this overactive inflammation that can happen in both upper and lower airways, including chronic rhinosinusitis with nasal polyps, or as abbreviated CRSwNP. We'll talk about biologic therapeutic regimens for patients with CRS with nasal polyps, severe asthma, and to address the pathophysiologic processes and overcome treatment-related barriers. So here's a pre-test question 1. Approximately how many patients with CRSwNP do you manage each week? Good music for you guys to answer. It's louder. All right. Let's move on to question number 2. Approximately how many patients with CRS with nasal polyps and comorbid asthma do you manage each week? Here's question number 3. Which of the following plays a key role in orchestrating the upstream activation of both T2 high and T2 low or non-T2 inflammatory pathways in upper and lower chronic inflammatory airway diseases? 1, TSLP, 2, interferon gamma, 3, IL-17, and 4, IgE. So if you guys will all answer. All right, question number 4. Based on the EPOS euphoria criteria, which of the following is one of the requirements necessary to consider biologic therapy in a patient with CRSwNP who has bilateral nasal polyp recurrence after sinus surgery? 1, FeNO less than 10 parts per billion, 2, SNOT22 less than 20, T3, evidence of non-T2 inflammation. I'm sorry, number 3, evidence of non-T2 inflammation. And number 4, daily low-dose oral corticosteroid use for the past 3 months. Question 5, Jane is a 35-year-old woman with a 15-year history of T2 high asthma and 10-year history of CRS with nasal polyps, with surgery 10 years ago. Although her asthma symptoms are well controlled, she has experienced large bilateral nasal polyp recurrence since her last surgery, despite intranasal corticosteroids and 3 courses of oral corticosteroids. What would you recommend for Jane at this time? We're coming close to the end of questions. Approximately how often do you currently consider the presence of comorbid asthma when choosing a biologic therapy for patients with CRSwNP? Thank you for participating in those questions. So let's talk about the unified airway model, what it means for patients and clinicians. So it's important to think of the unified airway model, and it's basically upper and lower airway disease reflects a single pathologic process, and it just shows up in different areas of the airway. So for our top, it's allergic rhinitis, nasal polyps, CRS without polyps, AERD, and in the bottom, asthma is a big one. But now more and more evidence suggests that other conditions, including eosinophilic COPD and eosinophilic bronchiectasis, may be lower airways. So upper and lower airways are connected, similar pathologic mechanism and process, and Amber will talk about it a lot more as well. So what is some of the supporting evidence for this unified airway model? Epidemiologically, we know that in patients with nasal polyps, up to 70% have comorbid asthma. And in patients with asthma, up to 40% have comorbid nasal polyps. In terms of pathophysiologic evidence, mechanistically, severe asthma, especially severe eosinophilic asthma, CRS with nasal polyps, and those individuals with AERD, the aspirin sensitivity, asthma and nasal polyps, they commonly have similar cells, inflammatory cells, including eosinophils and similar cytokines, IL-4, 5, and 13. Again, upper and lower airway, very similar. And this is a busy slide, and Amber's going to spend a lot of time going over this. Just know that the pathophysiologic mechanisms are similar in terms of cells, both in type 2 and type 1 inflammation, both in upper airways and lower airways. Other evidence includes in people with allergic rhinitis. Why is this so important for us to think about it? Allergic rhinitis is a classic type 2 inflammatory disease. It's very common. Up to 25 to 40% of the population is affected by allergic rhinitis. It is one of the most common chronic conditions in the US, and lots of money is spent based on lost productivity, where people either don't work as well, take off from work, don't do as well in school, etc. Similarly, chronic rhinosinusitis is very common. Potentially 5 to 12% of the population in the US is affected. About 20 to 30% of patients with chronic rhinosinusitis have associated nasal polyps. And there's a lot of lost productivity associated with this as well. And lastly, asthma, which goes hand in hand with these two conditions. More than 25 million individuals in US are affected. And of these, 5 to 15% have severe asthma. These are the people who are the high healthcare utilizers, These are the people who get admitted to the hospital, go to the ER, get frequent courses of oral steroids. So let's talk a little bit more about impact of comorbid disease in the unified airway model. About 40% of patients with chronic rhinosinusitis have comorbid or premorbid allergic rhinitis, so they go hand in hand. Asthma and nasal polyps occur in 40 to 70% of patients, as we talked about earlier. And the more severe asthma you have, the more likely you will have more severe CRS radiographically and higher risk for nasal polyps and being allergic. In fact, asthma is one of the most important risk factors for CRS recurrence after surgery. We know majority of people with asthma have concurrent rhinitis, and patients with asthma who also have allergic rhinitis are more likely to have asthma exacerbations and ER visits for their asthma exacerbations. A little bit more evidence to show you the comorbid united airway model. There's higher rate of nasal polyp recurrence and steroid dependence in those with asthma. Those with more difficult to treat asthma, as I mentioned, tend to have worse nasal polyps, tend to have polyps, and also a lot more symptoms. And these are individuals who have both upper and lower airway disease, are more likely to have asthma exacerbations, as has been shown in many of the severe asthma populations, including both here in US and in Europe. They tend to have worse outcomes, both for upper and lower airways, compared to people who either have only upper airway disease or lower airway disease. So whenever we think of upper airways, think lower airways. When you think lower airways, don't forget upper airways. And let's hear from Amanda, who is a patient with a long history of both severe asthma and CRS with nasal polyps.
When the asthma diagnosis first came, the physician that I was working with, their first line of defense was to try oral corticosteroids. Unfortunately, that seemed to be the only line of defense for about 4 years. I was continuously on oral corticosteroids. I was told they would work wonderfully to control the symptoms, they would help with the inflammation, I would feel so much better, and all of that was true, but it wasn't explained to me that that they're detrimental, that it suppresses your immune system and that it can have long-term effects. I definitely think I wouldn't have been as eager to take the steroids if I had realized the long-term, damaging effects. It definitely in the short term affected my appetite, affected my sleep. I even started to get they call it a moon face, where, the weight gain was distributed in that way. So I definitely think that that's something patients should be made aware of before they start taking that medication. I've been told by my eye doctor that I have signs of cataracts. I'll be 50 tomorrow, and so it's early, and he said that that's from long-term steroid use. In addition, when I had my daughter, which was 11 years ago, they had to give me IV steroids prior to delivery because they were afraid of how my immune system would respond. Other than that, I seem to have returned to normal. I don't have any other, thank gosh, lasting effects. But again, definitely things that I didn't take into account. So about 4 or 5 years into my asthma diagnosis, my pulmonologist decided that we would try biologics. And the first biologic, it worked great at controlling the asthma, and it worked for several years. And I didn't realize that I may at some point have to change medications. I didn't realize that the medication may stop working at some point. And I found that out when that's what happened. I started to have asthma flare-ups that required prednisone use. And at that point, my physician recommended we try another biologic. We tried that. It worked wonderfully for the asthma. However, it did not help control the sinusitis. So at that point, we made a switch to the third biologic, which is what I'm currently on. I've been on it for about 5 or 6 months. And this biologic has worked wonderfully to combat both the asthma and the sinusitis. When I was told that I needed sinus surgery to remove the polyps, it wasn't explained to me that the potential for recurrence was there. I thought that I would just have a single surgery, remove the polyps, and that would eliminate the issue. That wasn't the case. I had to have 2 subsequent surgeries for a total of 3 to remove the polyps. And I now realize that the potential for another surgery is there. I think it's very important for physicians when they're working with patients that have asthma and chronic sinusitis that there be transparency. I think a physician needs to let their patient know that we're going to try a course of treatment. This may work, this may not work. This may work for a short time, and then you may find that we need to switch. I definitely think that for me, I would have had a more realistic expectation of my course of treatment. I think it was a surprise to me when the first biologic plateaued, and I wasn't finding the same response that I was getting before. So I think transparency is definitely important. And on the flip side, I think it's important that patients report back to their physician what they are experiencing. Don't feel like you're complaining. You need to let someone know how you're feeling and what symptoms you're experiencing so that they can be addressed.
So key points from the patient perspective. There's significant disease burdens that accompany the chronic inflammatory airway diseases. Providers should discuss the chronic nature of chronic rhinosinusitis and asthma with their patients. And just as the patient suggested, set expectations about typical disease course and the risk for exacerbations, recurrences. And when discussing sinus surgery, for those of you guys who do surgery, and for all of us who do medical management of upper and lower airway diseases, providers should communicate typical onset of benefit and duration of efficacy, as well as potential for short and long-term adverse effects. I'll pass it on to Dr. Long.
All right. So we're going to do a little bit deeper dive into understanding the pathophysiology of what results in this unified airway. So, as Dr. Peters Anju had talked about, there's a lot of overlap in terms of the disease presentation, but why is that the case? And so part of it is not only is the upper and the lower airway physically connected, as you can see there, but there's a lot of commonality in terms of the cellular architecture in both the upper and the lower airway. So as you can see, you've got that respiratory epithelial cells that are ciliated. You have them both at the upper and the lower airway. You have goblet cells. So there's a lot of similarity in terms of what the anatomy looks like, the cellular anatomy. And then underneath, you have a similar matrix of submucous tissue. And consequently, they're being bombarded by a similar environmental triggers. And so it's not surprising that you get similar inflammatory responses that we have now characterized as type 2 inflammation that you're all aware of, and also some of the type 1 inflammation that I'll talk about. So this type 2 inflammation, the first thing you need to understand is this anatomy of the epithelial barrier along with these goblet cells. And so you've got these potential triggers that you and I are being bombarded by all the time, viruses, bacteria, antigens. And so these can all trigger these epithelial cell-derived cytokines. So we're starting to understand that the epithelial cell is not just a physical barrier, but rather an important component of the immune response. So you have these cytokines such as TSLP, IL-33, and IL-25 that then can activate these two different arms of the immune response. You've got the innate immune response and the adaptive immune response. And most of us are pretty familiar with this adaptive immune response with, type 2. Initially, we used to call them Th2 responses because they were primarily linked to the T helper cells. So you get activation. And then it results in these cytokines that we've all are fairly familiar with now since the introduction of these biologics, but those key cytokines associated with the type 2 immune response. You've got the IL-5, which is important in eosinophil, IL-4 important in the activation of the immunoglobulin production, and then IL-13 responsible for mucus production and so forth. But it's important to realize that you've got this interaction of both the innate and the adaptive immune response. And because of the similarities, you can see this happening in both the upper airway and the lower airway. And so just to reiterate some of the key players associated with this, these are the alarmins, or also epithelial cell-derived cytokines. You've got the IL-25, IL-33, and TSLP that we haven't really talked much about yet, but they're the main orchestrators. They're the ones that kind of activate this whole immune response, but they're more upstream. And then, of course, those that are associated with the more classic type 2 immune response, which is your IL-4, IL-5, and IL-13. And it's important to remember that they're activated not only by the T helper cells, but also by innate lymphoid cells. So it's this interaction that we see resulting in some of these clinical phenotypes that we are treating on a daily basis. Now, although chronic rhinosinusitis, nasal polyps, and asthma and allergic rhinitis have been clearly linked to type 2, it's important to remember that there are also non-type 2 mediated inflammatory pathways that also can play a role in some of this chronic inflammatory disease that we see. So these cytokines, especially those that are released from the epithelial cells, such as the ones that I mentioned in addition to IL-6 and IL-8, can be important in activating neutrophilic kind of the central effector cell. And these two pathways, neutrophilic responses, so through the Th1 response or this type 3 response. And there's a little bit more data for IL-17 in triggering asthma. But we're starting to realize that these different inflammatory responses can also play a role in these diseases. And so, as I mentioned, the IL-6 mediated airway inflammation has been a little bit more worked out in asthma, as you can see here, that it's important in not only establishing the chronic inflammatory response, but also important in the exacerbation. But there are also papers, actually ones that Dr. Peters was involved in, that looked at a dysregulation of this IL-6 pathway in chronic rhinosinusitis, although the molecular pathway per se and the details are not as worked out as it is in asthma. So just to make sure that you guys are all awake and paying attention, here's a nice audience response question. Which of the following is an epithelial-derived cytokine? 1, IL-4, 2, IL-13, 3, TSLP, or 4, IL-10? Very nice. So lots of people paying attention. IL-4 and IL-13 are more derived from those T cells and innate lymphoid cells, but TSLP is, in fact, an epithelial cell-derived cytokine. So let's zoom in because, we're rhinologists here. We're going to, Dr. Peters is an honorary rhinologist, but we're going to focus in a little bit on the upper airway here, and specifically allergic rhinitis. So allergic rhinitis, as you all know, is kind of mediated primarily by an overproduction of IgE, and it's that recognition of antigens to these IgE that then triggers the activation of these type 2 cells. The effector cells here are going to be your mast cells and your type 2, your eosinophils, basophils, and mast cells. But they all are also producers of these type 2 cytokines, and so perpetuates this phenotype that we describe as allergic rhinitis. But all of them, when we think about a disease, we think about the phenotype, which is what we can clinically diagnosed, but then what is the molecular etiology of this disease? And in allergic rhinitis, it's fairly more homogeneous. It's clearly a type 2 immune response. Now, chronic rhinosinusitis with nasal polyps, although most of us have been, listening in the audience more in these, meetings, more associated with a type 2 immune response. But it's important to realize that it's not just a type 2 immune response. And so the phenotype here is your inflammation of the lining of the sinuses, mucus production, which we'll talk a little bit more about. But that, although there is a strong association with the type 2 immune response, there is also data to show that type 1 and type 3 inflammatory processes, more of your neutrophilic picture, more of your interferon gamma, can also play a role in chronic rhinosinusitis. And so a nice study came out of a local institution here, Northwestern, looked at these characterizing these patients with chronic rhinosinusitis with and without nasal polyps, and look to characterize what is the cellular mediators associated with these diseases. And although, as you can see in that right pie chart, most of CRS with nasal polyps can have the single type 2 inflammatory profile. But you can see, look at the purple, it's a pretty significant wedge, and that's a mixed type 1 and type 2 response. And so, what I want to highlight here is that it's not just a homogeneous type 2 inflammatory response. And of course, that's going to have implications in the treatment of these diseases. So just another, hey, are you paying attention? Which inflammatory pathways are involved in the clinical manifestation of CRS with nasal polyps? 1, type 1, 2, type 2, 3, type 3, 4, all of the above, or 5, none of the above. All right, so a majority of us got it right. Yes, there is evidence to show that all three of these different types of inflammatory processes can ultimately present with CRS with nasal polyps, the phenotype that we treat. All right, so some of another link of the fact that this upper and lower airway is the fact that a lot of these presentations are very similar in the upper and the lower airway that is of inflammation. So the mucus hypersecretions, the swelling and the edema that can happen in both the upper and the lower airway. And then unique to the lower airway, because there is the presence of smooth muscle cells, which we don't have up in the upper airway, is the smooth muscle contraction and the hypersensitivity, the hyperreaction that can happen in the lower airway. And so with nasal polyps, similarly, these inflammatory pathways can lead to nasal polyps. But in addition to that, there's been a lot of research coming out in addition to whether it's the trigger or the consequence of these inflammatory processes, but the loss of the epithelial barrier. So although the epithelial barrier is really a very critical part in the immune response, it does also serve as a barrier to the environment. So we know that there's breakdown of this barrier. This also then, of course, results in the inflammation that we see in the recruitment of these inflammatory cells that lead to this inflammation, as well as the mucus production that we saw in the previous slide. So ultimately, all of these play together and result, although we don't have the actual details of how these nasal polyps form and the progression of it, but we do know that all of these different aspects, the tissue remodeling, the loss of some of these submucous glands, the epithelial barrier defect, and this inflammatory response all sort of lead to this production of nasal polyps. And so it makes sense when you have all of these things going on that it represents some of the more severe patients that we have to treat. So, going back to what Dr. Peters talked about, this unified airway, I think that the data and the pathophysiology, the shared, cellular anatomy, it helps to explain why we are seeing this, unified airway, and the results of, as Dr. Peters mentioned, that the same sort of similarity in types of inflammatory responses that can occur results in different presentations in different areas of the upper and lower airway, resulting in the disease that we call as allergic rhinitis. So it's causing the nasal itching, the irritation, and the sneezing associated with allergic rhinitis. For CRS with nasal polyps, its inflammation can result in, physical blockage, causing, smell loss, as well as inflammatory effects on the nerve itself, resulting in decreased smell, facial pain and pressure, sleep disturbance, and then of course asthma with the congestion and the inflammation resulting in chest tightness and hypersensitivity. So with that, I will turn it over to Dr. Hahn.
Okay, thank you. And so let's talk about addressing the using biologics in treating our patients with chronic sinusitis and how that affects both the upper and lower airway. So when we look at the biologics that have been approved for both asthma and nasal polyp, these are the three that are bolded. So omalizumab came out first for approval for asthma, then came mepolizumab, and then dupilumab. And you can see that they target different cytokines that are involved in both the upper and lower respiratory disease, as you heard earlier. And so more specifically, when we look at omalizumab, which is what it does is it binds to the circulating IgE, which then prevents the IgE to bind to the Fc epsilon 1 receptor 1. And then when for anti-IL-5, we have mepolizumab. And what mepolizumab does is it binds to the circulating IL-5 so that it doesn't bind to the IL-5 receptor alpha. And then we also have anti-IL-4 or dupilumab, and what it does is it binds to the IL-4 receptor, and what dupilumab does is not only blocks IL-4, but also blocks IL-13 together, and I think that's critical and what makes dupilumab effective. But even though we have robust treatment options for our patients with asthma and nasal polyp, there is still a little bit of an unmet need. There is no FDA-approved treatment, biologic treatment for allergic rhinitis, and I'm not sure if we're ever going to get that. And there is no biologic that's been approved for non-type 2 chronic sinusitis or asthma. And yet we know that, as you heard earlier, that there's ample evidence to show that allergic rhinitis definitely is involved not only in chronic sinusitis, but also in asthma. And these patients who have both asthma and nasal polyps usually have severe quality of life. And so then when we look at other biologics that are currently approved for asthma, but undergoing phase 3 trial for chronic sinusitis with nasal polyp, we have benralizumab. And so benralizumab actually finished their one of their phase 3 data called the Austral data, and that's out and been published. And then the second one just got finished. They had their last patient recruitment last fall, so we should be getting their data this fall. The other biologic that has been approved for asthma but has finished their last patient recruitment is Waypoint or tezepelumab. So tezepelumab targets TSLP, and Waypoint, as I said, had their last patient recruitment last fall, so we should be able to get some of that data this fall. Now, so how does tezepelumab and benralizumab work? And so as you heard earlier, what tezepelumab does is it binds to the TSLP, and TSLP is one of the 3 alarmins that we see. And I think of the 3 alarmins, TSLP, I think probably is the most significant one. And what's unique about TSLP, as we heard earlier, is even though asthma and nasal polyp is mostly type 2, you can see that it also has non-type 2 inflammation. And so what TSLP can do is not only target the type 2 inflammation, but it can also target the non-type 2 inflammation, as you see here. And benralizumab, the way it what benralizumab is different than mepolizumab. What it does is it binds specifically to the IL-5 receptor alpha. And what that does is it also causes antibody-dependent cellular cytotoxicity. So what it does is it actively kills off the eosinophils. So that's why you see the eosinophils drop pretty quickly with benralizumab. And so the other things and how these biologics relate to allergic rhinitis, as you may have heard recently, omalizumab got approved for treating food allergy, and it does target allergic type diseases like asthma, as well as non-allergic type asthma. And then the TSLP does have a study looking at patients with allergic rhinitis and asthma, but it is a phase 2 study. So going back to Amanda, we see that she has severe nasal polyp and asthma. She's been on multiple surgeries, but she also had multiple biologics. And so you kind of wonder, is there a way that we could have maybe done a better job? And so instead of her going through all the different 3 biologics to the point where it finally worked, could we have done a little bit better and trying to figure that out a little bit better? And so let's talk about that. Now, this is a paper that was written, and this is actually the second version of this paper from the EPOS and Euphoria. And what we did was we defined, what patients should be given a biologic. And I'll go into it in more details, but patients who've had sinus surgery and there's recurrent nasal polyps after a sinus surgery, they say that you should meet at least 3 of the 5 criteria in here, and let's go into that a little bit more details. Now, this is a paper done by Adam DeCon, and he did a really great job in kind of showing that chronic sinusitis with nasal polyp is a chronic disease. And so it's like diabetes and hypertension. Once you have the diagnosis, it doesn't go away. I know that, even when I was undergoing training, we would say that if you have nasal polyp, you do surgery, it make the polyps go away. But I think that's not true. It's kind of like saying that you give a patient insulin injection, their sugar goes down, but then now they get cured of their diabetes. That's not true. And same thing with nasal polyp. Just because you have sinus surgery doesn't mean the polyps disappear. You have to do surgery plus medicine afterwards to prevent the polyps from coming back. And that's what this paper shows. And so, and as you heard earlier from Amanda's nice testimony, you can see that she's had 3 sinus surgery. So she has severe nasal polyps, and she's tried 3 different biologics as well. And so let's ask the audience, in your clinical experience, what % of your patients with chronic sinusitis with nasal polyp have recurrence of nasal polyps after sinus surgery? So A, none, 2, 25%, 3, 50%, 4, 75%, 5, 100%, and number 6, I do not manage patients with chronic sinusitis with nasal polyps. Wow, so you can see that there isn't anybody who said that the polyps never come back. You can see it's anywhere from 25 to 75% of patients where the polyps keep coming back. So I think that's true to what we talked to earlier and what Adam DeCon papers have written. And so one of the questions is, how many surgery is too much for our patients with nasal polyp? And then, when do we start biologic? And so this was a paper by Eugenio De Corso from Italy. And so what they wrote this paper talking about, when do we decide to do that? And I think one of the first things, if I have a patient who has surgery that gets referred to me for recurrent nasal polyp, one of the first things I do is get a CT scan. And the reason why I get a CT scan is to make sure that all the sinus cavities in these patients with nasal polyps have been opened up completely. And if it hasn't been, I would consider doing a revision sinus surgery to open it up. Now, appropriate sinus surgery has been done and all the sinuses have been opened up, I would certainly consider giving a biologic to these patients. And, in patients with severe asthma, certainly do a multidisciplinary approach and talk to the pulmonologist or allergist to try to figure out, what biologic would fit well for this patient to target the asthma and nasal polyps. Now, if the patient had sinus surgery and it's been like 10 or 15 years since they last had their surgery, and over time the polyps have come back, these are patients that I would maybe consider doing sinus surgery again instead of considering a biologic. I certainly talk to the patient and ask him, hey, what do you think about, instead of doing sinus surgery, what do you think about considering a biologic? And if they say no, I would say that would be another patient that I would consider doing sinus surgery on. Now, if this patient had sinus surgery within a year or 3 years of having the surgery, this is a very aggressive systemic inflammatory disease process. And so these patients, do you want to keep doing sinus surgery again and again? And I think this is a patient that may benefit from a biologic, or a patient whose asthma is poorly controlled or needs to be on steroids or has steroids on a regular basis. These are patients that I think would be a good candidate for a biologic. And, just like when we treat patients with chronic sinusitis, medically, we tailor what medicine we give them based on what type of disease they have. I think is also true for nasal polyps. When we do sinus surgery, I think the type of surgery that we should do should be tailored based on what type of sinus disease they have. And in patients with severe nasal polyp, these are the patients that I make larger openings and make sure we get all the polyps out. And in this study, they did Lothrop, which is opening with the frontal sinus, and with that, the recurrence rate of the polyps has been a little bit slower. And so one of the questions that, as ENT doctors or rhinologists, one of the benefits is that we can actually incorporate both biologic and surgery. And so, when do we do one versus the other, or a combination of the both? So let's talk a little bit about that. So this is that EPULSE Euphoria paper. And, when we were writing this, one of the things that we wanted to say is that a lot of patients with chronic sinusitis with nasal polyp, even though it could be type 2 and non-type 2, majority of patients with nasal polyp is usually type 2. So one of the questions was, how do we tell our readers how do we define that they have type 2 without, if you're not measuring IL-4, IL-5, IL-13, how do you define that? And so this is one of the ways we've kind of defined what is type 2. And so we say high tissue eosinophils, having elevated blood eosinophils, or having elevated IgE, or maybe even a combination of these two. And so if you have one of these biomarkers that are elevated, certainly we would consider them being a type 2. Now that is a low bar, but still one of the things that we wanted to kind of define. Now, the other patients that we should consider biologic, is severe nasal polyps, or, recalcitrant nasal polyps. So how do we define that? And the way we defined it is patients who are needing recurrent systemic steroids. And so, or their quality of life is severe, or the sense of smell is diminished. And of the different cardinal symptoms associated with sinusitis, loss of smell seems to go really well in patients with nasal polyps. And we know that, as you heard earlier, systemic steroids work well in patients with asthma and nasal polyp, but with that, it comes long-term comorbidity and complications. And so one of the things that we talked about is, how much steroid is too much in our patients with nasal polyp. And I think in general, a lot of the experts are saying if you're using more than 2 systemic steroids in a year, that's too much. And that's similar to what we see in asthma. And so if you're taking more than 400 milligrams of systemic steroids for asthma, that is too much. And if you look at 2 courses of systemic steroids for nasal polyp, that's about 500. So similar to what we see in asthma. So going back to Amanda, as you heard earlier, steroids worked. It helped her get better. but it did cause long-term complication for her. It was the weight gain and the cataract formation. And I think going back, would she have done things a little bit differently? Probably, if she had a little bit more information and options. And so what are our therapeutic options to try to minimize the use of systemic steroids in our patients with asthma, allergic rhinitis, or chronic sinusitis with nasal polyps? And so let's ask the audience, in your clinical experience, what % of your patients with chronic sinusitis with nasal polyp and asthma prefer to continue long-term oral corticosteroid as opposed to starting a biologic therapy? 1, none. 2, 25%. 3, 50%. 4, 75%. 5, 100%. 6, I do not manage patients with comorbid chronic sinusitis with nasal polyp and asthma. Okay. Yeah. Okay, great. All right. So it's evenly split. Okay, fantastic. Okay. So so I'd like to ask Anju and Amber, what do you guys think? I mean, in your experience, what % of your patients with nasal polyp and asthma would rather be on systemic steroids or a biologic? And so I'll ask you, Anju, first.
I would tell you in my patients, if they had the option of being on long-term oral corticosteroids or biologics, 0 would say they'd want to be on long-term oral corticosteroids. So I'm not sure what the audience was thinking here, but none of mine would.
Well, so I think
they take short courses
Yeah.
for when symptoms are bad, and we know steroids work very well and are needed for exacerbation. It's the long-term courses that we used to have people on it for asthma, and some of them were people with ARD, but now I feel like they...
So I think some of this results may be because of the fact that we're practicing in different centers, right? So in the academic centers, we're going to see a lot more like severe patients like Amanda who have become educated in their disease, right? So they've lived through some of these complications, and so they can tell you, dude, that worked great, but I'm so over the weight gain, especially my women patients. They're like, I gained like so much weight after just 2 courses, and they know better to say something. So, back to this question that you had, Joe, about therapeutic options. Luckily, we're starting to have more options, right? So some of the things we'll do is just, we've been playing with some off-label ways to get steroids into their nose, as well as some other, mechanisms. So the exhalation delivery devices for fluticasone. So all of these stem from the fact that we are trying to find other solutions for these long-term oral corticosteroids.
I think, though, one of our biggest, and this is why I'll tell you, none of my patients would, I think we as treating physicians and clinicians, one of our biggest jobs is, because when people take steroids, as you said, they feel great. Mm-hmm. But our job to educate them that, no one wants to have cataracts early, weight gain, like you mentioned. And I think we just need to, and good thing is there's enough research now showing all of the bad side effects that can happen even with those short courses of oral steroids, especially in asthma. And people with asthma and nasal polyps go hand in hand, and people get their oral steroids in so many different places. Urgent cares. Mm-hmm.
Yeah, that's the problem, right? ENT. To your point, is that sometimes we're not a coordinated multidisciplinary team helping, right? So, Joe had talked about multidisciplinary treatment, but unfortunately, their multidisciplinary team members may not be talking to each other. So their pulmonologist is giving them a course of oral steroids. I'm giving them a course of oral steroids. They're going to the urgent care and getting them. So unlike our narcotics, where we have a system where we can see how many times has this patient been given narcotics and they're getting the prescriptions, we don't have that for oral steroids, and maybe we should. So that way we can figure out from patients like, oh my gosh, they think they've only had 2 courses, but they've actually had 5 courses, right? And so we need to intervene and say, this is maybe a little bit too much. And
I think, like Amanda said, one of the things that, I use oral corticosteroids. We need to use them when people are sick with exacerbations. But one of the things when people call and ask for oral steroids, one of the things I tell my patients is, I know you would rather be on steroids right now, but you don't need it. We do different ways to tell if they need it or not. And I tell them, in the long run, after a few of these courses, once you have side effects, you're going to tell me, I wish I hadn't taken all of these. So I think the biggest things we all can do, and electronic medical records actually help us some.
Yeah.
Like if you look back at prednisone, put it in that magnifying glass, and then you see how many courses of steroids some people have had, it's quite, unfortunately, shocking.
Yeah, and I would say, like Amber said, our coordination of treating our patients has not been very good until recently when we started getting together with the allergists and pulmonologists and ENT, and we created the Severe Asthma Consortium, and now we talk to each other on a regular basis. Now, there is one more group of specialists that we haven't really incorporated and starting to realize that we need to, and those are rheumatologists. Yeah. And so rheumatologists also give a lot of systemic steroids, and they often see a lot of our patients. And these patients with chronic inflammatory diseases are there. And so now we're starting to realize that I got to include the rheumatologists in these discussions. All right, so I'm going to. And then finally, one of the criteria is asthma. And the reason why we wrote asthma in there is because asthma is such an integral part of the disease in our patients with nasal polyp. And the fortunate thing is if you have nasal polyp and asthma, biologics works better in these patients. So if you have asthma by yourself and you give them biologic, or if you have nasal polyp by itself and you give biologic, the patient who has asthma and nasal polyps together are the ones who tend to do the best with these biologic. And so that's why we put that in there. And so I'm going to turn this over to you about mucus plugging.
Yeah, thank you, Joe. And I think that what you mentioned about asthma and polyps together is exactly what, Amber, you had shown with all that pathophysiology. It's because they tend to be very type 2, so it works well. Let's talk about mucus plugging. For those of you who deal with patients with asthma, know that many of our severe asthmatics, actually, when you do a chest X-ray on them, it looks just fine. But if you do a chest CT, you'll see that there actually is some airway damage there, and sometimes you'll see mucus plugs. And the more mucus plugs you have, the more likely it's correlated with airway obstruction, so lung damage, increased need for more asthma medication, so they tend to have more severe asthma, more frequent exacerbations, and increased risk of potentially airway infections. And some of us feel that this is what eventually leads to some of what we see as bronchiectasis in our patients with asthma, and often with comorbid upper airway disease. So there is a way to assess for these mucus plugs, and it's done on the CTs. You score the mucus score, 0, low, or high, depending on how many lung segments you observe that have mucus plugs. I wish we could share with you a picture, so you have to think of it in your head. Close your eyes and think about it. You see airways, which should be nice and black, and instead you'll see these white areas that are mucus plugs. And as I mentioned, the higher the mucus plugs score, the more likely to have more airway obstruction that may potentially not even normalize with treatment, as well as higher RV, higher TLC, so a lot more air trapping, not able to get the air out, which is the problem in asthma. So Amanda mentioned that one of the biologics she took helped with asthma, but not with her CRS with nasal polyp symptoms. And we see that every so often. A biologic may help the upper airway or potentially lower airway. Sometimes helps both, sometimes only one or the other. So this is a question I'll ask my colleagues here. How do you weigh the decision to switch biologics when one of the disease entities is well controlled, but the other is not? Dr. Luong, do you want to start?
Yeah, so this luckily doesn't happen too often. Because of some of the pathophysiology that we talked about, there's a lot of times a similar pathophysiology. So if one is being controlled, typically the other one is. But I have seen some patients where you do see this situation. And so, basically the one that obviously has Anju, you mentioned, right, the asthma will send you to the ER. So the last thing I want to do is take someone off of their biologics if they have this baseline of a very severe, very brittle asthma. So I don't just because I see polyps and it's not as ideal as I would like, but they're being well controlled in their asthma with their biologics, I don't necessarily say, well, let's try something else. That's where we really do need to be in communication with the pulmonologist and have this discussion and say, here's what's going on. They're symptomatic from these polyps. I'd like to see if we can try to get them better controlled, but I don't want to just switch it without your consultation. And so with that consultation, then I would say, okay, maybe consider trying another biologic would be, and I have seen that where, then they will respond to both the lower and the upper airway with switching, but I wouldn't want to just do it on the fly.
I think that makes sense. How about you, Dr. Hunt?
Yeah, so, it's actually interesting. We talk about multidisciplinary approach being important and increasing quality of care, but the communication is not very good among the providers. It's not going to function very well. So in the past, what I used to tell the patient is, oh, your asthma is well controlled. Can you tell your pulmonologist to consider this biologic? Or can you tell them, what do you think about this? And I had the patient communicate that for us. Horrible. Because, what did the patient know? I mean, they tried to explain it, but they couldn't explain it. And so now, with that Severe Asthma Consortium, we actually just call each other, text each other, and, we have dinners every 2 months. And so we talk about patients and, and it's a much better way of communicating. And I'll give you an example of a patient that I saw recently that was on a biologic. That biologic helped with their asthma and nasal polyps. And it got to the point where the pulmonologist said, okay, your asthma is doing pretty good. Let's get you off the biologic and increase your topical medication. Well, it's fine because they stopped the biologic, they upgraded the treatment for their asthma, but they didn't do anything for the nasal polyp. So 3 months later, the patient comes back, the polyp is getting worse, and the patient's saying, I'm off the biologic, my asthma is now okay with this new medication, but my nasal polyp is worse. So that's where, that communication is so important. And so then I said, so I called the pulmonologist, the next time you want to make some changes, please let me know so that I could, increase their treatment for the nasal polyp as well. And so that's what we did. And then now their polyp is under better control. So that communication is really important. And I definitely talked to the pulmonologist and the allergist, and, they may know something or they may be thinking about something that you're not thinking about. And together we usually try to pick the right biologic for the patient.
I think that's so true, the multidisciplinary work. So I'm going to hand it to you.
All right, thanks. So, one of the things that, we want to talk about, is, if we give a patient biologic, can we change the disease process? And this was a paper that we wrote. And, we use the word control, remission, and cure. And this was, I think, a very ambitious paper. But this was a paper that the EPOS and Euphoria wrote together. We had a lot of discussions. We had meetings on this. And we finally had this come out because, we see that the pulmonologists and the allergists are talking about, control, remission. They haven't talked about cure. So we took one step ahead and talked about cure. And so how do we come up with this definition? And so here's our definition. And these terms apply to diseases that are chronic. So this is these are terms that you hear for like rheumatoid arthritis and asthma. And so we said, if someone's in control, is when their symptoms are under control, they don't need any steroids for at least a month. Remission, we said that their symptoms are under good control and don't need any intervention. And when we talk about remission, we could say it's with medicine or without. Rheumatoid arthritis do that all the time, but the only medicine that we would not include in the remission is systemic steroids. So if you're on systemic steroids within the past 12 months, you're not in remission. We actually had a long discussion about that, and we said, some of the people said, if you get steroids and, it's still with medicine, so it's still in remission. Well, eventually, I think we realized, that's probably not good because long-term use of systemic steroids is bad. And then we said, if the patient has these symptoms under good control, we made the ambitious decision to say that they're cured. Now, whether or not that's going to hold true or not, it's out there, and I'll curious to see what you guys think. In Europe, this is probably a very common concept that they talk about. I think in the U.S. is something that I think we're starting to have discussions on. And so, if you have put a patient on a biologic, one of the things that you're going to get from the insurance company is, they're going to ask you, is it working? Because if the insurance company feels like you put them on a biologic and they're not getting better, they're going to stop. The insurance is going to stop it. And I've been seeing that more often. And I've been seeing patients come back. They're coming to see me every 3 months or 6 months. And I'm saying, why are you coming back? They said, the insurance company said that I need to come back and make sure it's working so that they can continue paying for it. And so one of the questions that we said was, how do we define if a biologic is working? And initially, when we came up with this idea of whether it's responding or not, we said 4 months. And part of that was based on the GNI guideline. But we realized that that's probably not the appropriate amount of time. So we switched it to 6 months. And I think 6 months is more appropriate because if you look at a lot of the clinical studies for biologics for nasal polyps, 6 months is usually around the point. And usually that's where you can kind of decide whether it's working or not. And so that's why we said 6 months, and if they're better, monitor them again in 6 months. And if they continue to do well, we usually do every year or every 3 months or 6 months, depending on the payers. And then, and one of the things that we wanted to define is, what is a good response or versus a poor response, and those are the criteria that we had come up with. And, one of the things that we talked about in this paper are, what are treatable traits? What are things that we can treat and look at and see if we can make it better? We talked about remodeling, and remodeling is such an important disease in chronic diseases. So, like, for example, rheumatoid arthritis. If you have chronic rheumatoid arthritis that's not well controlled, what you're going to have is start deformity of the joints. If you don't have good control of the asthma, you start getting fibrosis. Fortunately for our patients with nasal polyp, if you don't control it, you will get more fibrosis of the polyp. And these are the ones where you put them on a biologic, they won't get better. But fortunately, we as ENT doctors can do sinus surgery to get rid of these fibrotic nasal polyp and try to reset it to zero. And so that's one thing that I think we have that among our patients with nasal polyps that I think the other chronic diseases don't have. And certainly disease modification is something that we want to aim towards. And I'm not sure if we're there yet, but certainly something that we're thinking about. And so I think...
Thank you. So just like Dr. Han mentioned, this whole concept of remission is so important in all of the chronic diseases. And again, remission is not same as cure. In the Euphoria guidelines, we did say remission is on medicines, but not oral steroids. Similarly, remission has been defined in asthma. There have been a couple of important papers. This was a paper from 2020 and it was a Delphi survey approach. There were some asthma experts who came together, and just like Euphoria, the time course was a year, so 12 months, with or without asthma treatment. Again, remission, all of us, well, not all, but most of us think you could be still on treatment, but absence of significant asthma symptoms based on validated questionnaires such as ACQ. Lung function stabilization we think is important in asthma remission. And then the important thing about remission criteria should be that it should be clinically feasible. It's something that we should be able to do in clinic, measure in clinic, and patient and the clinician should be agreeing on this. And just like we did in Euphoria, the Asthma Delphi survey approach also said no use of oral corticosteroid therapy for exacerbation treatment or long-term disease control in that 12 months. The American College of Allergy, Asthma, and Immunology, and the American Academy and the American Thoracic Society came out with other clinical criteria for remission for treatment of asthma, again, 12-month period. And they said, as we've been talking about it, remission's not same as cure, and that remission could be defined in those who were also on biologics. And these stringent criteria are listed. Basically, you shouldn't have exacerbations needing steroids. You shouldn't miss school or work for 12 months because of your asthma. The lung function should be stable and optimized. You can continue use of your asthma medications such as topical corticosteroids, LABA, leukotriene antagonists, etc., but at low to medium dose of inhaled steroids, because we do know that there's potential for adverse effects with high-dose inhaled steroids. Again, validated questionnaires such as ACT, which is really easy to do in clinic. We do it all the time, ACQs, etc., and symptoms requiring only reliever therapy with albuterol no more than once a month. So again, stringent criteria for 12 months. What we do know that with biologics, potentially we can reach this definition of remission, and the one that is mentioned here is tezepelumab, the one that blocks TSLP, the alarmin that is on the upper side just below the air, released by the airway epithelium and then leads to more chronic type 2 inflammation. And what tezepelumab has done and has shown that it is potentially disease modifying in asthma, and other biologics that treat asthma have shown similarly that the effects are sustained while you're on the biologic. And once you stop the biologic, your symptoms may come back. Your biomarkers that show inflammation may start going up again, but typically do not go back to baseline. So you're still doing better than before when you started the biologic. And with tezepelumab, this was shown up to 9 months after the last dose. So potentially, there is a potential for expanded indications of some of these biologic agents in the future. We think of remission. How would that benefit the current patients with allergic rhinitis, chronic rhinosinusitis with nasal polyps, their treatment regimens that we use? Would you want to address this first, Dr. Long?
Yeah, so obviously this is only beneficial to us, right? If we could have some of those biologics that are currently indicated only for asthma and expand it over to CRS with nasal polyps, because currently we don't have a cure. But some of these other biologics, unlike the current ones, which are all targeting the same sort of downstream type 2 cytokines, may actually address some of these non-type 2 pathways, which we know is playing a role, an important component, not only as asthma, but in CRS with nasal polyps. And that's what's frustrating to me right now, because we thought we had the magic bullets, right? Because we had all these 3 different biologics. What's the likelihood of going through all 3 of them and not having one that responds? But I have seen patients who don't respond to it. And it's really those patients with CRS with nasal polyps, a little bit older patients who have these mucoid or recurrent infections at the same time. So it's sort of evidence of this type 1 non-type 2 pathway that's playing a role. And so having some of these new biologics that are approved for asthma may actually go a long way in helping that population of patients that we are now struggling with, or even some of the CRS without nasal polyp patients that we struggle with. So I think it can only be good.
I think what you mentioned about these infectious type, that's some of that mucus plugging, and there are studies that show some of these biologics do decrease those mucus plugs, which probably have some type 2 inflammation, but non-type 2 neutrophilic inflammation. How about you, Dr. Han? What do you think?
Yeah, no, so I kind of echo what Amber said. That's, I think the biologics that we have been a huge addition to our treatment of patients with recalcitrant nasal polyps. So these are patients that have been suffering a lot. These new biologics that have been approved for nasal polyp have been really helpful in a lot of these patients. But there are still some patients with nasal polyps where it hasn't completely fixed their problem, and so often we'll still have to do surgery even when they're on the biologics. So, is there still room for improvement or addition? Yeah, I think so.
Yeah, thank you.
So some key takeaways, so as we heard earlier, we know that a lot of the disease in the upper and lower respiratory airways are very similar. They have similar pathophysiology. We know these patients with nasal polyp and asthma have the more severe disease process because I think it's more of a systemic disease process that we see. I think biologics that have been introduced have been a great addition to treating our patients, both for asthma and for nasal polyps, and it has really improved patient outcomes. And I do think that a good multidisciplinary approach where you communicate really well amongst the specialty is really important. And so with that, I like to ask some of the questions, okay? So, so if you've been listening to our lecture, you should be able to know a lot of these questions. So which of the following plays a key role in orchestrating the upstream activation of both T2 high and T2 low or non-type 2 inflammatory pathways in the upper and lower chronic inflammatory airways? Number 1, TSLP. Number 2, interferon gamma. 3, IL-17. And number 4, IgE.
Audience questions. You want this one?
Okay. Sorry, I got my hands full.
What?
All right. All right. So it looks like a lot of people said TSLP, so great. All right. Number 2. The next question is, based on the EPOS Euphoria 2023 criteria, which one of the requirements is necessary to consider biologic therapy in patients with chronic sinusitis with nasal polyp, with bilateral nasal polyp recurrence after sinus surgery? So 1, a low FeNO. Number 2, a low SNOT-22 score. 3, evidence of non-type 2 inflammation. Or 3, low dose oral corticosteroid used for 3 months. All right, great. All right, thank you. All right, everybody seems to got that. Majority of the people got that right, so great. All right, let's ask the next question, question 3. So Jane, who is a 35-year-old woman with a 15-year history of type 2 high asthma, T2 high asthma, and 10-year history of chronic sinusitis with nasal polyp, with surgery 10 years ago, although her asthma symptoms are well controlled, she has experienced a large nasal polyp recurrence since her last sinus surgery. Despite intracortical steroids and 3 courses of systemic steroids, what would you recommend for Jane at this time? 1, repeat sinus surgery. 2, repeat sinus surgery and increase systemic corticosteroids. 3, repeat sinus surgery and start biologic therapy. And 4, follow up in 3 months. Okay, great. So everybody seems to think this sinus surgery plus biologic treatment afterwards. Okay, fantastic. Question number 4, approximately how many will you now consider the presence of comorbid asthma when choosing biologic therapy for patients with chronic sinusitis with nasal polyp? 1, never. 2, 25% of the time. 3, 50% of the time. 4, 75% of the time. 5, 100% of the time. And number 6, I don't manage patients with severe asthma and nasal polyps. Okay, so a little bit of 25% of the time and 100% of the time. All right. All right, so now we'll have a time for Ask the Experts question and answer session. And so,
Well, since I had the longest amount of time to look at these questions, I'll start first.
okay, all right.
And wants you to email them.
So one question was presented. What are the are there any specific patient or disease factors that predict nasal polyp recurrence? And so that actually goes back to that post-test question number 4, like would you consider asthma? So it turns out the presence of more of these type 2 inflammatory conditions in a patient is a risk factor for recurrence of nasal polyps. Has been discussed here a couple of times. Those patients who have both the CRS with nasal polyps and asthma are the ones that are more likely to recur, have more severe disease in both the upper and the lower airway. And then some specific patient factors is, of course, one of the issues we have is compliance with the topical medications. We know that sinus surgery, one of the benefits, even though, as Joe mentioned, our sinus surgery is not curative, but it does provide access to the diseased mucosa. And I feel like that's still a huge advantage versus other disease processes where you don't have access to that organ. So for example, asthma, it's a little bit more challenging to get the steroids in there. But if the patient cannot be compliant, and in Texas, I see a lot of patients with CRS with nasal polyps and allergic fungal rhinosinusitis. These guys present at, in their 20s. It's really hard to get a young person who's going to college to think about their doing their saline irrigations twice a day and some sort of topical steroids. So those types of specific patient factors are going to be a risk factor for recurrence. Anju, your question?
Sure. Mine is, are there any biomarkers for CRS with nasal polyps, like pheno or blood eosinophils can be for asthma? Yeah, for asthma, we definitely have some biomarkers that help guide treatment as well as how someone will do, and so help in choosing biologics and in how, so for example, and I'll tell you asthma, if a pheno is high and blood eosinophils are on the higher side, biologics such as tezepelumab and dupilumab do much better. In terms of CRS with NP, we don't have good biomarkers. We definitely have some clue. So for example, if someone's had surgery, you can look at the biopsy and pathology and see if there's high eosinophils, just like Dr. Hahn showed with the Euphoria guideline. Greater than 10 high power field is what we have in the Euphoria guidelines, although in other places they'll say it's a higher number. So those tissue eosinophils, if they're on the high side, suggest the disease may recur. Clinically, if they have asthma, aspirin-exacerbated respiratory disease, allergic fungal rhinosinusitis, those are all markers of more severe disease and likelihood for recurrence. And there's some evidence even with blood eosinophils potentially, even though blood and tissue don't completely correlate, that yes, it may be associated with more disease recurrence.
I think pragmatically, though, it's sometimes difficult to get your pathologist to stay on board with giving you those high power field counts for eosinophils. So, I don't know about you, but I'm at an academic center and you would have thought that they would easily just do that. But I have to wrangle them all the time and say, hey, can you give me something more than just eosinophils are present? I mean, is it lots of them or not? Trying to get some sort of, so that sometimes these markers, although they sound great, are not practical yet.
And so geographically, I think, like you said, depends on where you are. Ours, it took us a long time, but finally, and sometimes depending on who reads it, they may just say eosinophilic predominant or neutrophilic or lymphoplasmacytic. Yeah. But that's, again, CRS with nasal polyps, biomarkers are a huge issue. And you want biomarkers that you could just check for easily, like the IL-4, IL-13 and stuff that we show in our research studies. We can't take that into our clinical practice.
Although there is some research now going into where we can try to, there are some people who are looking to be able to just put a quick leuko paper in there, which we use for research purposes, and then maybe a company can just take that paper from you, spin it down, and give you some sort of profile. And it's not out of the realm of possibilities, right? So I think that might be coming down.
That'd be awesome.
Yeah. And then I have 2 questions, but I think it was similar to the first one with biomarkers. for the success of a biologic, and I think we kind of talked about that. And then the next question is, what do you think about eosinophilia in general? And so, Amber?
Yeah. Hey, I saw that. That question was for you. I gotta love Joe. So eosinophils, at least in the upper airway, is kind of a controversial issue, right? Because there is a drug and a study that showed that if you can eradicate eosinophils, that doesn't necessarily change the polyps. And so that really confused us, because for like 10 years we talked about how evil eosinophils are, and that they were the cause of all problems. And then there's this medication that got rid of the eosinophils, and some of our biologics, they get rid of all the eosinophils, and yet you see the polyps. Now, I have to say that the polyps look cleaner, so you don't have the eosinophilic mucin in those patients, but the polyps are still there. So, but yet we do know that when we're just talking about it, if you look at the tissue at the time of surgery, and those patients who have high power field counts of eosinophils, they are more likely to have higher disease. So it's very confusing, and so I don't know if we have a good answer. But now I understand why you kind of nicely lobbed that over to somebody else.
Yeah.
And you know, what's actually really interesting, so that drug did nothing in nasal polyps, which got rid of eosinophils. So it's been studied in asthma, and it's been studied in asthma in a small study, and there's going to be larger studies. It does show some benefit. Isn't that interesting? So here it's unified airway. Here we're saying getting rid of eosinophils doesn't matter. Here getting rid of it does seem to matter.
Yeah, no, and but that paper. So everybody always talks about dexpramorprexol making the eosinophils go down, the tissue eosinophils go down. But what they also in that paper also talked about was the mast cells, and actually the mast cells went up.
Yeah.
So you kind of wonder, is eosinophil the only inflammatory cell that is responsible? And I would say probably not.
No,
so there are other cells that are involved, and just targeting the eosinophils is not enough. I would say, one of the things that, when I think about eosinophils, I do, in the past, before biologics were approved for asthma, I rarely ever drew blood eosinophils. But because blood eosinophil was such a good predictor for a biologic working for asthma, I started to do it because a lot of our pulmonologists didn't want actually to write the biologics for their asthma. So I had to do it so that I could give them the biologic. And over time, what I've realized is that certain patients with nasal polyp have higher eosinophils than I thought. And so, the trend that I've seen is patients with high eosinophils greater than 1,000, like 2,000, 3,000. A lot of these patients who have asthma, when I've been measuring the ANCAs, C ANCA, P ANCA, or even getting biopsies of the polyp and sending it to ask the pathologist to look for vasculitis, I've been finding patients with EGPA that I would have not normally found. The other thing that I think is important is when we look at eosinophils, by definition, if someone has a blood eosinophils greater than 1,500, that is hypereosinophilic until otherwise proven. So you have to figure out what is causing the eosinophils to rise up that high? Is it drug-induced? Is it infection? Lymphocytic? So you got to think of all those different things as well. So those are my general thoughts on eosinophilia.
I totally agree, because I got the question. Whoever sent it and said something about dad has eosinophilia.
I think they wanted to keep that private.
No, it says it, right? I'm not giving anyone's name.
Okay,
what I'm saying is, if someone has that much eosinophils, they really should go see an eosinophil expert. Like you mentioned, it could be more than upper airways. You need to look. There can potentially be things that, you may even need to see a hematologist or an allergist focusing on eosinophilic condition. Because as you said, till you figure out what's causing this hypereosinophilia, it can be way more than just asthma or polyps.
Yep, that's right.
So we have another question. Can CRS without nasal polyps be treated with biologics? And if so, how would you initiate the biologic treatment? So technically, there is no biologic that is approved for without polyps. That being said, if those patients, I mean, we just talked about, and the pathophysiology talked about, that even in patients without nasal polyps, there is a significant component that has a type 2 profile. And so you would expect that there could be a response in those patients. But that being said, I think getting through the pragmatic, being able to write that prescription, that patient probably needs to have asthma or some other clear indication for the biologic. But I would expect that you may get some improvement. But and then when we're looking at some of those, like Tezi having the TSLP, well, that can activate some of those non-type 2 pathways. So in that patient population, I would expect, some response, some positive response in that patient population.
I agree.
Yeah.
All right, we just have a few more minutes.
Okay.
Any other questions or thoughts?
John, I had a question. That's a great panel. Amber, you said endoscopic sinus surgery is not curative, but are biologics curative?
No.
And then secondly, you said the patients that don't want to take the saline sprays and steroid irrigations, I don't think we can help them with just biologics alone. Wouldn't you agree we need the combination? So that patient, that young patient that doesn't want to take both, I don't think they're going to do well.
Yeah, I mean, that's a very fair point, right? So it does make the compliance a little bit easier, right? It's something daily versus something 2 weeks. But you're right, at least at this current stage, it's not that easy sometimes to get, the prescription. Once it's sort of initiated, then yes, it shows up and every 2 weeks they're getting it. But then sometimes if they switch insurance, that becomes another issue. And our young people population is not going to necessarily go that extra mile to get that treatment. So I agree with you that compliance in that younger patient population is probably more complicated than whether or not they're willing to do their saline sprays and irrigations and topical sprays. Back to your other question about curative, you're right. So that's why, back to that question that Anju brought up, is another biologic going to help armamentarium? Yes, because the fact is we don't have anything that's curative. So the more options we have until we get that cure, the better we're off, because not everyone's going to fall into the responder bucket.
Do you think we'll ever get to the cure?
Yeah.
Joe?
It's a lofty goal.
Well, so I will say, what our experience, so we have like 200 plus patients on biologics for nasal polyp. And what we've seen is that in our experience, the patients who have been started on a biologic, the ones that I remember are the ones who stopped the topical steroids. But when we looked at, how many patients really stopped the topical steroids, it was only about 20 to 25%. So about 80 to 75% of the patients still needed some type of topical steroids. But I would say about 20% of the people could get off the topical steroids and did well with just the biologic alone. Now, with that being said, I was asking a lot of our pulmonary colleagues and these experts who do lots of work with biologic and asthma. And when I asked the pulmonology colleagues, they said they get similar data. Like a lot of the patients, about 20 to 25% of patients are able to get off their ICS-LABA with just the biologics. When they get the biologics, 20, 25% were able to get off. Now, with that said, there is a prospective, product registry looking at patients that got one specific biologic. And when they asked these patients, and they were following them prospectively, how many of the patients still stayed on the topical steroids, it was only 35%. So that means like 60 to 65% of the patients got off their topical steroids and are just taking the biologics. So we are getting a little bit differing numbers, but I wonder if the truth is somewhere in there. And so, and I think that, biologic and asthma is different than biologic for nasal polyps. And we're seeing that. And, as we have biologics longer and longer, we're starting to see, the durability effect, all these other things that all the questions that you're talking about. So I don't think we have the answers yet, but we're getting there. And we're starting to answer some of these questions that you're talking about. Any other questions? Yes.
It's interesting to see the evolution of steroid treatment from systemic to intranasal steroid spray. And now everyone is talking about intranasal steroid wash, how more effective. Will we be able to have a biological wash local?
So the question is, because of the different transition from going from oral steroids to topical steroids and then putting it into your saline irrigation, do we ever see a time where there could be some modifications in the biologics to minimize the systemic effects and maybe being able to put it in topically? So I would say it probably is not going to be a systemic biologic per se, but there are some other options that are going to be very similar, maybe like short peptides that are going to be a little bit more stable in a saline irrigation, or some mechanism to be able to get the recognition below the epithelial cells, right? So the biologics, as we went through very quickly how they react, is so IL-5. Well, IL-5 is not on the epithelial cells and it's not on the topical. So that IL-5 has to get in. Well, so TSLP, but then the TSLP is still released into the tissue and not into the lumen. So it still has to, the drug still would have to get through the epithelial barrier, or at least affect the, on the receptor of the epithelial cells. So there's going to be some, right now, there's some limitations of being able to look at that. But I do agree that there may be some other, not currently antibodies, but maybe peptides or some other mechanism that are small enough that can, or that can be penetrated through or picked up by the epithelial cells that may do the same thing as our biologics, but they're currently not available right now. But yeah, that's an excellent thought, and that's definitely some things that people are thinking about.
Yeah, and I would say that question is almost prophetic, and so I'll just leave it at that. But I think that is something that a lot of people are thinking about. Now, with that said, if you have a patient that's on a monoclonal antibody, you know it's a monoclonal antibody because at the end of that fancy, syllables and everything, it ends with a MAB, right? Which stands for monoclonal antibody. Now, in 2020, there was an article written that no longer uses MAB anymore, and now has 4 different suffixes, right? ART, IG, TUG. I don't know if you knew all this stuff. So now a lot of the new biologics that are out there have these different suffixes, and it means something. And so like ART, if it ends with the ART, it's an artificial immunoglobulin. And so a lot of the stuff that you're talking about is forward thinking, and I do think that, like Amber said, you're going to see some new stuff coming out, and it's not going to end with just what we see here. It's going to go a lot further. All right.
You want to end it?
All right. Well, thank you very much, and we'll be here at the end if you want to ask us more questions.
Thank you.
Thank you. All right.